Fisher. I'm the founder, chief medical officer and CEO of Check for Cancer. I come from a background in breast cancer surgery and research. Check for Cancer is completely focused on early cancer detection, so through prevention, screening and diagnostics. But today I'm going to talk about skin cancer and some of the challenges we face in trying to diagnose skin cancer early. So let's look at some of these challenges. So the incidence of melanoma has risen by more than 150% in the last 3 decades and over 30% in the last decade. But there are far greater numbers of non-melanoma skin cancer, so squamous cell carcinoma and basal cell carcinoma, which is by far the commonest type of skin cancer. And actually non-melanoma skin cancer has been increasing even more than melanoma. So almost 170% increase in the last 3 decades and over 40% in the last decade. So a rising cancer incidence that's reflected internationally, not just in the UK. We've heard already about all the workforce issues in the UK, and this is a chart showing the number of doctors and nurses per head of population in the UK. Nurses in the y-axis, doctors in the x-axis, and we're down in that left-hand corner. So we have a major workforce problem that existed and has just got worse post-pandemic. So how does that affect dermatology? Well, a study from the Getting It Right First Time team 3 years ago looked at the consultant workforce and identified that about 24% of consultant posts were vacant. So there's a huge, huge issue in trying to recruit workforce into dermatology. And I think just in general, it's not seen as one of the most interesting specialties, and that's now reflected in what's happening. But this isn't just a UK problem. This is happening worldwide. And so the American Association of Medical Colleges also looked at this in 2021, and they're forecasting a shortage of over 120,000 dermatologists by 2034. And you can see they are dealing with massive numbers of melanoma and non-melanoma skin cancer. We've always thought there was quite a lot of underreporting for non-melanoma skin cancer in the UK. And so this study, which was carried out looking at the incidence in 2018, went to cancer registry data to try and look at this. And you can see that they have estimated that in 2018, there were 215,000 skin cancers diagnosed. We only diagnosed 375,000 cancers overall in the UK, so this is well over 50%. And you can see by far the commonest type is basal cell carcinoma. It's not surprising then, with this rising cancer incidence, that urgent cancer referrals, the chart on the right, have almost doubled since 2015. And the most worrying thing is that patients with a lesion that's suspicious of a basal cell carcinoma are not eligible for the urgent 2-week wait pathway. So many of them will wait up to 18 weeks to be diagnosed and then even longer to be operated. So one of the things that came out of this was that there was a statement by the NHS and the British Association of Dermatologists saying that trusts should work with their GPs, look at their local communities and try and work out the best way to diagnose skin cancer early. And they encouraged the use of telemedicine and teledermatology. So we run a teledermatology pathway, not just for melanoma, but for all skin types of cancer. So patients who have a skin lesion that has changed recently, according to that pink box in the top left-hand corner, these are the symptoms that allow someone into this pathway. And we have a network of nurse-led clinics throughout the UK where we can see people quickly. We can see 94% within 10 days. At these clinics, the nurses, who are all experienced in dermoscopy, take really high-quality images, SLR, dermoscopy, and they collect all the clinical information. And that's uploaded for telemedicine reporting, and we have got a team of really experienced telemedicine reporters 2 of them have over 20 years of experience. That's how long telemedicine has been around. So for everybody that comes into the pathway, in general, we reassure about 80% that no further investigations are required. Of the remaining 20%, just over half will have a biopsy and 4% will be diagnosed with skin cancer. So this is a really effective pathway. If you're interested in early cancer detection, 96% of melanomas diagnosed in this pathway are stage 1 or 2, where the survival is much, much better. And if you compare that to national figures from NHS Digital, it's 85% for men and 89% for women. So we are definitely performing above that level. So the real challenge is, well, why can't we just make this available to more people? And this is the answer. We've talked about it already. We've got a shortage of skin cancer nurses who are trained in dermoscopy. We have a shortage of experienced telemedicine reporters, and that's crucial to this. And then we have long waiting times in both the public sector and the private sector to get a biopsy if you need it done. So this is exactly the same as being reflected worldwide. It's kind of perfect storm, rising cancer incidence and huge workforce shortages. But what we can do is we can use the information from this pathway. We know all the details about the patients, their clinical features. We know whether they had a biopsy. They know their final classification to suspicious or not suspicious. So we have the opportunity to do something innovative with these very high quality data. And you'll hear this time and time again. The accuracy of your AI model is directly proportional to the quality of the data that you use to build it. So we've got some challenges in the UK that really reflect international challenges, rising incidence, workforce shortages, but we have these things that are peculiar to the UK. We have long delays in diagnosis and treatment of skin cancer, and we have this issue with basal cell carcinoma that patients are not eligible for the urgent 2-week wait pathway. So the problem is, how can we scale this teledermatology pathway given all these challenges but maintain the high performance that we have achieved to date with human reporting? So the solution is to use these data to build an AI model to help classify patients into suspicious or not suspicious categories, and we can use all of that information that I've described to build this AI model. And what I want to do is share some of the early results with you. It's very much early results. We only created the research data set 20 months ago. So everything I'm going to talk about from now on, we've done in the last 20 months. And I know we've still got lots to do, but the results are really encouraging. We're also developing an app, which is another solution to aid this problem of access, which can help people take really high quality images at home. But for now, I'm going to focus on the AI model. So we have an AI model that's hosted in the cloud that the human reporting team can have access to as a decision aid to help classify lesions to either the suspicious category, which requires a further face-to-face assessment and possible biopsy, or reassurance. So we embarked on this. We got a grant from Innovate UK, and we've done a knowledge transfer partnership with the University of Essex. In total, we've used almost 80,000 images from just under 20,000 patients. Most of the patients have more than one lesion of concern. So this is the architecture. We have skin images, so an SLR image, a dermoscopic image as input to the model. We started with 22 pieces of clinical information for every patient, and we've distilled that down to the top 7. And we've actually produced a novel risk score by looking at the ranking of those 7 risk factors and weighting them. We heard the talk earlier about intellectual property and how you maintain that. We've actually managed to publish that risk score without releasing the ranking or the weighting of those risk factors. So there is a way of protecting your IP and publishing in good journals without exposing your IP. The actual AI engine is an efficient net model, 3 different models which fuses the output from the images and the clinical risk score to categorize lesions as suspicious or not suspicious. So how have we done? You know, that's the measure. How successful have we been? How accurate is the model? And how can we compare ourselves and benchmark ourselves against others? So these are the 7 risk factors. They're not in the ranked order, and I've obviously not told you the weighting. But we actually published this in Nature Scientific Reports in September of this year. So you can publish in good quality scientific journals without exposing everything that you've done. So let's look at the accuracy. So remember, this is a pathway for diagnosing all skin cancer types. It is not focused just on melanoma. So if you look at column 1, that's the sensitivity for each of those skin cancer types based on the images alone, and column 2 is the images and the clinical risk score. And what you'll see is that most of the figures are around the 88, 89%, 100%. But what the clinical information does is, if you look at the benign row on the bottom, it increases the benign sensitivity, which is really your specificity. And you want that to be as high as possible, because that will reduce the number of unnecessary recalls for further investigation. So you're always trying to get a balance between sensitivity and specificity. Now, how are we benchmarking ourselves? We've heard about skin analytics. I'm sure you'll all have heard of them. They're doing a lot of work in the NHS. And so I've just taken some of their results from their website 2 months ago just to compare ourselves. And I think you can see from their results that we're sitting very comfortably against what they've done. But perhaps the most important thing is, how do we compare ourselves with published results of face-to-face assessment using dermoscopy? Because until now, that is the gold standard. And so we've used 2 Cochrane databases, which come up with a kind of best practice sensitivity of 96% at a fixed specificity of 80%. And again, we sit really comfortably beside that. Now, bearing in mind that the Cochrane databases can only assess published data. That is usually consultant-led, and it's usually expert. And one of the previous speakers came up with an overall sensitivity for skin cancer detection of 88%. So I think there is a way forward here which says that actually we can help a lot of telemedicine reporters and people doing this triage to improve their accuracy by using these kind of data. The model that we built can be used as a decision aid. That's the simplest way that it can be used, and that will help less experienced teledermatology reporters to benefit from all the experience that we've harnessed in our particular model. However, you can also use it to automate the triage process and to create efficiencies in your pathway. And if you run all the images through the AI model first, it will detect those that it calls suspicious, and they can go straight to face-to-face assessment. But the other really interesting thing is, by using a different version of the model, we are looking to identify a proportion of the non-suspicious group with a really high degree of confidence that we can safely reassure. Now, this all comes down to what was being discussed by the panel. It's that balance between accuracy and safety and risk. And so this needs a lot of work, and these are the kind of projects that we're continuing to do, and we are very much, I think, at the start of our journey. We're definitely not at the end of our journey. So how do you determine success? How do you build that trust? Well, you know, you've got to benchmark yourself against published data, against human reporting, and you've also got to build that evidence. I think the most interesting thing from our perspective is the clinical information gives you a huge advantage. And most of the current models for AI models for skin cancer classification do not include any clinical information. The first thing medical students are taught is that history taking is 80% of the diagnosis. Now, that's not quite true, because I've looked at that paper and it's based on about 50 patients. But the history taking is hugely important, and I think we've been able to include that in our model. And that will help us to increase the specificity and reduce unnecessary recalls. How do you bring the clinicians in? That's one of the things we've said we have to do. Well, we stepped into the lion's den. We presented at the British Association of Dermatologists earlier this year. Until about 3 years ago, they were against teledermatology, never mind the inclusion of AI. But they actually ran a session this year on teledermatology. So it was good to be able to go and present it there. We've presented at the IEEE International Conference on Digital Health in Shenzhen in China in April. And as I said, we've published in high-quality journals. We're very fortunate that we work in the insured and the private market. So we have an existing market where when we get regulatory approval, we can deploy this in our own teledermatology pathway. And I think this will help us to scale up and do more work with the insurers we already work with, and also to attract new insurers. But we do want to work with the NHS, and everything I've heard in the last 2 days is that is going to be a significant challenge. And I suspect we're going to go down the route of talking to a health innovation network rather than trying to set up a pilot study, because it seems the success rate of that is incredibly low. But we're here, we've got a stand on B8, and if anybody wants to come and talk to us, we'd be really pleased to do that. So the next steps. Obviously, we've got to get regulatory approval for that. That's an even bigger conundrum at the moment. Do you go for the UK? Do you go for the EU? Do you go abroad? And you know, we're exploring all of those just now. We've got a prospective audit of our AI model output with human reporting. Obviously, the human report blinded to the AI model. We're expanding our work on explainability. That's really important if you want to take clinicians with you. You have to tell them why the model is saying what it's saying. Show them a heat map. Show them which bit of the lesion it's looking at. So there's lots we can do to improve that. You've heard about trying to make sure that your model helps everybody. And we have to, you know, say that our UK model is built on Fitzpatrick's skin types 1 to 4. It's not been tested in darker skin tones. But we've got a further grant from the BBSRC, and we're actually looking at that now. How can we look at our model performance and improve it in darker skin tones? And so I think there's lots we still need to do. There's lots of challenges, but the goal is huge, and we should keep striving to achieve that. So finally, I'd just like to thank all members of the team. We still work with the 3 academics at the University of Essex. Shafiq, who's on our stand and who's here, was the research associate in that project, and he now works for us as a data scientist. So thank you very much.